Welcome back. We're having our third and final conversation this morning, and as we mentioned, it's all about brain tumors. What do you know about brain tumors? Well, if you don't know, we're going to be sharing some information with you, and we have an oncologist here with us to talk to us about that. His name is Dr. Ramon Yacab, and he has up to 12 years experience in medicine, and of course, of those 12, 6 as an oncologist. Good morning, doctor, and welcome.
Good morning. Thank you for having me.
No problem. So for our viewers who may not be wholly familiar with what an oncologist does, like myself, can you give us a bit an idea of the work of an oncologist? And it's not somebody's uncle that makes you an oncologist, right?
No, it's a very good question. Oncologist is a specialty in itself that deals with cancer. That's what we deal with. My part, I am specifically a medical oncologist. So my role is to help patients establish a diagnosis of a cancer, guide them, assess them. Once the cancer has been diagnosed, we talk about treatment options. We give them, again, assessments there. We talk about chemotherapy. We offer chemotherapy. We offer hormone therapy, immune therapy for the treatment part. We offer palliative care and end-of-life care for patients who have incurable cancers. And we also offer follow-up for patients. Now, there are other types of oncologists. For example, a surgical oncologist who will only deal with the surgery aspect of cancers, and radiation oncologists.
What made you decide to specialize in oncology in the first place?
I do consider that it's a vocation for me. I mean, ever since I was at med school, I felt that I had that inclination, that calling to be with cancer patients. I mean, seeing the suffering that they were going through inclined me to this. I came back to Belize and I started doing volunteer work, the Belize Hospice and Palliative Care Foundation a few years ago, visiting patients at end of life. And I did see that there was such a need for Belize. I followed studying in Mexico, came back, and this is what we're doing. So I see cancer patients on a daily basis. Mostly they're at KHMH. I also do private at Belize Healthcare Partners, but I also do volunteer work. I am the Vice President for the Belize Hospice and Palliative Care Foundation, advocating on behalf of patients with advanced disease.
How has medicine advanced over the years to where a cancer patient no longer has to feel as if this is the end of life as we know it?
Yes, and that's a very good question. And I'll try to put it in when it comes to cancer, unfortunately, it will depend on the systems that we have in place. Up to 50%, 60% of cancer cases can be detected early. I mean, and the most frequent types of cancers: breast cancer, cervical cancer, colon cancer. If we're able to detect the cancer early or prevent it, as in cervical cancer, we shouldn't have a conversation on end of life. However, around 40% of all cancer cases are coming in with a stage 4 cancer.
Yeah.
And for all instances, a stage 4 cancer is not curable. And while we may not want to talk about end of life, the conversation will need to be discussed at some point because the patient will pass away from the cancer.
What is a conversation like when it comes to end of life? One would imagine that's difficult. How difficult is it to have that conversation?
It is difficult. I mean, especially having that first discussion with the patient, knowing that it's an advanced cancer. The first thing is we always have to build that rapport with the family, with the patient. And we go step by step. We don't just tell them it's this and that. No. We have a deep conversation with them, exploring what their thoughts, what their beliefs are. and how much information they want us to divulge to the patient at that initial point.
Yeah.
And we build a very good relationship with the patient. And I have to mention that when we have these conversations, the patient is the captain of the conversation. I'm there to support the patient on what he or she wants to know, and I'm there to support their decision.
Since we're on this topic, provide us with some information, a brief insight on the stages and the severity of each stage, if you would.
Yes. So most of the cancers use a standard classification that goes from stage 1 to a stage 4. Most of the cancers. We have other types that we use a different classification. But for most part, a stage 1 cancer is a very early detected cancer that, depending on the site, surgery might be the only consideration. Stage 2 and stage 3, the size of the tumor has grown to potentially affect areas around it. And the treatment may involve surgery, chemotherapy, and or radiation, depending on the type of cancer.
To remove it.
Yes, to try to remove it.
Yes.
And a stage 4 cancer, while treatment options are available, the treatment options are palliative. A surgery is done to help with symptoms, not the cure. Radiation is offered to help with symptoms, not the cure. And chemotherapy is offered to prolong life, help reduce symptoms, but it's not a cure. So
At that point, it's essentially just to keep the patient as comfortable as possible.
yes, so when we have that stage 4 cancer, and we're offering all of these modalities, these fall under the umbrella of palliative care,
Yes.
in which our mission is to keep the patient comfortable. At some point, the patient may become too weak to even continue any type of oncologic treatment, and we continue with only end-of-life care.
You mentioned another form of treatment that I'm actually familiar with, and that is immunotherapy. And I want to talk a little bit about treatment because I know that Belize still has quite a way to go when it comes to access to treatments for persons with cancer. You would know, doctor, that a lot of them would have to travel outside of the country to our neighboring countries to seek treatment for cancer. But let's touch on the different types of treatments and include in there what immunotherapy is.
So immunotherapy is a type of treatment that kind of restarts your immune system. It recognizes that there is a cancer, and it provides your body to build antibodies or that defense system to attack the cancer. However, immunotherapy has its own indications. We don't use it in every type of cancers, and when we're using it, it's also in most instances, for example, in breast, colon cancer, lung cancer, it's in the metastatic setting, meaning it's in patients who do not necessarily will receive a cure, it's to prolong. So when we hear about immunotherapy, and even when we hear about chemotherapy, it all depends on the stage. If I use immunotherapy in a patient with a stage 3 cancer, the cancer can be cured, but it's given as protection for the patient. If I give immunotherapy to a patient in a stage 4 cancer, it is not meant to cure. It will help prolong, and it's one of the options that we can offer patients.
To keep them comfortable as possible.
To help, yes, reduce the symptoms of cancer. So it all depends, again, on the stage. We use immunotherapy or the same drug, if you may, with different objectives. It might be to protect, it might be to just continue as much as we can.
And then, of course, there's radiation as well that people do here. No, they do chemotherapy here in Belize, but they would have to go outside of the country for radiation.
Yes, so what we have available is, in terms of chemotherapy, we do have it available. Hormone therapy, we have it available, and immunotherapy, it is available.
Really?
It all depends on out-of-pocket finances, because immunotherapy, anywhere you go, is very expensive. It is. So if the average Belizean could afford it, I mean, that would be a different topic though. But it is very difficult to have it there for everyone.
Yeah.
Yes.
Now let's zone in a bit to brain tumor.
Yeah.
Yeah. Is that synonymous with brain cancer?
Yes. Now, brain cancers are a type of cancers that is generally rare in the adult population. Different in the pediatric population, brain cancers are, or brain tumors in general, are among the most common ones in children. However, by numbers, cancers in children, for Belize, for example, we'd be expecting around 12 to 20 cases per year for cancers in general. Now, in adults, we're expecting around 400 cases every year of cancers.
In Belize?
In Belize.
That's a lot if you look at our population.
It is. And if we were to add that every year we're having patients receiving treatment, patients prolonging life, patients having potentially curable cancers, and we have to follow up these patients. By the end of the 5 years, we're having over 2,000 patients merely there if everyone has a good prognosis. So the number of cases have been increasing. Brain tumors account for 1% of brain cancer. So it's not that frequent. It's not that frequent, but it does happen, and it is happening.
How does one identify symptoms of a possible brain tumor?
Yeah. That's a very difficult question to answer because brain tumors are not like the other types of cancers like the breast cancer or the cervical cancer that's giving you warning signs or which we could even screen. Most of the times, symptoms of brain cancer may include visual disturbances, seizures, headaches that are changing with time, and it can manifest sometimes like a stroke. You could have a patient that may have weakness of an arm. Next week, he's having progressive weakness of the leg. So we have to suspect that something is happening. And why is this? The brain it's like a computer, if you may. If we touch any place in the brain, it will have an impact in the body. Wherever the tumor appears, that's the manifestation that we're going to be having. So those are some of the most common symptoms that we're going to have. And as clinicians, we always have to be thinking, yes, it might not be frequent. We still have to think out of the box. There might always be a cancer there.
With what you just explained, is it observed that brain tumors or brain cancers are identified more at a later stage because of these symptoms?
Yes, most of the times when it's identified, it's when we have full-grown symptoms. And the other thing that makes it difficult is that the location within the brain. While we do have the neurosurgeons here that do a remarkable job with the patients, sometimes the tumor in itself, they cannot access it because it's very deep in the tissue. So we aim to take a biopsy, and depending on what we may or may not have available, sometimes patients' biopsies can be done here, or the tumor can be resected here. But if not, the patient has to be referred abroad for additional management.
Is there something that causes these types of tumors, or is this something that can be inherited from your genetics?
Yeah. Now, when we talk about brain tumors, and I think I'm going to do a big classification here. Brain tumors, we generally talk about those that develop in the brain or in the spine, if you may, in the nerves that derive from the spine. And it can either come directly, be born there, as in the case of tumors that we know as gliomas or glioblastomas, or it can come from a different site. For example, if a patient has a breast cancer, it can metastasize to the brain. If the patient has a kidney cancer, it may go to the brain. So that also is a manifestation. Most of the times when we have tumors in the brain, it's metastases from another cancer.
Okay. So there are very low chances that you might just have brain tumor.
There. Yes.
Okay.
That would come in second place, you'd say, after ruling metastases from another site.
Okay.
And what we do when we suspect, we ask for an MRI. MRIs are the gold standard that give us the characteristics to make us suspect even more that there is a tumor that was born there.
So in a case, in an event like that, is there one treatment available for both areas identified?
Yes. Now, for example, if we were to talk that it is metastases, unfortunately, wherever you go, treatment will always include chemo to cover from the brain down, to help cover all of that. But the brain is very special in that it is considered a sanctuary. It's protected, and as much treatment as I may want to give as chemo, it will not infiltrate the brain. So any disease in the brain has to be accompanied by radiation.
Radiation.
Yes.
Okay, so what does radiation do? Radiation penetrates into areas that other medicines wouldn't?
Yes, what they do, and there are different modalities, but one of them, the most common one is whole brain radiation, where the patient will receive X-rays or rays going directly to all the brain, but it triggers mostly the site where the tumor is, and it kind of like in layman terms burns the tumor. So it helps control.
Yes. Doctor, I have a question on radiation, because I'm not sure if viewers would recall, or yourself, Paul, but when we talk about radiation outside of the medical term, it's seen as something that causes cancer. For instance, they would say, don't stand in front of your microwave, the radiation can give you cancer. But then we're talking about radiation as a cure for cancer, or to fight cancer. What is the correlation there?
Yeah, it's different, the type of radiation, and I must mention that yes, there is a correlation, but it depends on the type. When we talk about radiation that causes cancer or is related to cancer as a risk factor, it's ionizing radiation, and that can be gotten, one, for example, exposures, like during World War II with Fukushima, with the atomic bombs, that type of radiation, that's one. Two, at the workplace, doctors, radiographers, technicians, they're exposed to radiation through the CAT scans, through the X-rays. They'll always have their little label there saying how much radiation they're being exposed to, because those are risk factors. When it comes to other types of radiation, even the cell phone has been questioned about, does it cause or not cancer? It does expose radiation, but there has been no conclusive evidence that it leads to a cancer. So even international organizations place the cell phone radio frequency as a possible carcinogen. We can't really say it does, but we can't really rule it out.
That's quite a thing there. With how serious and the rarity of brain tumors, do we have patients surviving this?
Yes, and it all depends when it's specifically only the brain tumor that it derives from the from there. There are patients who survive, but it all depends where in the brain and how large the tumor is, because it needs to be resected in totality. Now, that's one part, the complications and that derive from removing part of the brain, how will that affect in the everyday life? That's another thing that we have to consider.
Doctor, this has been quite an informative segment. I think we could go on and on, but I want to give you an opportunity to share with our viewers how to contact you if they feel that they would like to reach out to you, whether they have a family member that's diagnosed with a form of cancer, or if it's through palliative care. How can they reach out to you?
So, well, we could, I'm generally there at, if you need to contact me, I'm at Carl Huger Memorial Hospital. What you have to do is contact the hospital to make an appointment, and generally at the private part, it's going to be through making your appointment at Belize Healthcare Partners, and through Belize Hospital and Palliative Care. We are a group of non-profit organizations, so you could always reach us through social media for patients who are in the life care. Yeah.
Thank you so much for stopping by, sharing with us this information, and we hope that our viewers were able to get something from it that can be beneficial to them. Thank you.
Thank you for having me.
All right, we're going to take our final break, and when we come back, we wrap things up.